If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, AGP in the UK. In today's episode, we'll look at the NICE updates published in March 2026, focusing on what is relevant in primary care only. This month, none of the updated guidelines were relevant to primary care. Only one new guideline had some relevance: kidney cancer diagnosis and management. We will cover this briefly, focusing on diagnosis and referring to the relevant section of the NICE guideline on suspected cancer recognition and referral. Right, let's jump into it. Before we go into kidney cancer itself, let's briefly set the scene by looking at the NICE suspected cancer guideline. It is designed to help us recognize when symptoms may represent cancer and when to refer patients urgently. In urological cancers, we need to be aware that many cancers, including kidney and bladder cancer, may present with relatively non-specific symptoms. However, one symptom stands out as particularly important, that is, hematuria. Visible hematuria is the single most important red flag symptom for urological cancers. NICE recommends that we should make an urgent suspected cancer referral for bladder or renal cancer in adults aged 45 and over with unexplained visible hematuria, either without a urinary tract infection or if it persists or recurs after treatment of a urinary tract infection. So this is an important point. Visible hematuria, especially when unexplained, should always be taken seriously. At the same time, we should remember that hematuria can also be associated with prostate cancer. NICE advises that we should consider a PSA test and a digital rectal examination in patients with visible hematuria, as well as those with lower urinary tract symptoms or erectile dysfunction. However, prostate cancer assessment follows a separate pathway, so today we will just focus on renal cancer. Now, what about non-visible hematuria? This is less specific, but still important in certain groups. With unexplained non-visible hematuria, if this is associated with symptoms such as dysuria or abnormal blood test results, such as a raised white cell count. So the threshold is higher, but it is still clinically relevant. However, we should note that this relates to suspected bladder cancer rather than kidney cancer, as the urgent criteria for kidney cancer are based on visible hematuria. And while we're here, NICE also advises that we should consider a non-urgent referral for bladder cancer. I repeat, a non-urgent referral for bladder cancer in people aged 60 and over with recurrent or persistent unexplained urinary tract infection. Additionally, the suspected cancer guideline also emphasizes safety netting. If a patient does not meet the referral criteria, but symptoms persist or evolve, we should reassess and reconsider referral, always using our clinical judgment alongside the guideline. Now, with that context in mind, let's move on to the new kidney cancer guideline itself. Diagnosing kidney cancer in primary care can be challenging. In fact, patients with kidney cancer may present late or with non-specific symptoms, which may overlap with other conditions. So in practice, the diagnosis pathway for kidney cancer in primary care relies heavily on the features that trigger referral under the guideline on suspected cancer. This means that visible hematuria remains central. In addition, we also need to be aware that kidney cancer may present with more general symptoms like flank or abdominal pain, weight loss or fatigue. However, these are non-specific and on their own may not meet referral thresholds. So again, clinical judgment and safety netting are really important. Another important point is the role of incidental findings. Some kidney cancers are detected incidentally on imaging performed for other reasons, although in these cases, the pathway is usually driven by secondary care. In primary care, our role is mainly recognizing the features and making the referral, and after that, most of the diagnostic pathway takes place in secondary care. There, once kidney cancer is suspected, the main test used is a CT scan of the abdomen and pelvis, or if necessary, an MRI scan. On occasions, a contrast-enhanced ultrasound scan can be considered. So to summarize this section, Kidney cancer diagnosis in primary care is largely based on recognizing features that trigger referral under the suspected cancer guideline. Visible hematuria remains the most important red flag symptom. Non-visible hematuria can also be relevant for bladder cancer in higher risk groups. And because symptoms can be vague, safety netting and clinical judgment are essential. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.